Καλησπέρα σας κυρίες και κύριοι, καλώς ήρθατε άλλη μια Κυριακή στην εκπομπή μας Θέματα Υγείας. Απόψε θα ολοκληρώσουμε σχεδόν ένα κύκλο εκπομπών με τους συναδέλφους από την εξαιρετική ιδιωτική κλινική London Sports Orthopaedics και ο τελευταίος καλεσμένος προς το παρόν για αυτή τη σεζόν που έχουμε απόψε είναι ένας εξαιρετικός επίσης ορθοπεδικός, ο Mr Ali Abassian. Welcome to our program.
Thanks very much.
Thank you very much for coming, especially such a terribly cold evening. And Mr Ali Abassian, he's a consultant orthopedic for NHS at the prestigious Guy's and St Thomas Hospital. He's a foot and ankle specialist. He has his private practice at London Sports Orthopaedics with the other doctors you have met in our previous episodes, and he's also a lecturer at King's College Medical School teaching orthopedics to the young doctors. So academic and NHS and private, multi-skilled, very nice.
Thank you.
So today we will talk about other joints because we have heard from your colleagues and the team you so nicely work together a few things about other joints. So today you have some nice samples here.
I've got some feet.
Exactly. Yeah. And some bones, and I think you will be very good. And as a lecturer, I'm pretty sure you will be very educative for our viewers.
Good. So what I wanted to start talking about, one of the conditions that I see quite a bit in my practice in the foot is bunions.
Yes.
You must have come across bunions quite a bit.
Yes. Excuse me. Είναι αυτό που λέμε στα ελληνικά κότσι, για όσους δεν το ξέρουν. I just explained in Greek because some people might not know the terminology.
Sure.
Yeah.
Sure.
Thank you.
So bunions, as you know, sometimes, I don't know if your viewers can see, is where there is a bump on the side of the foot. And what that makes, it makes the foot quite wide and makes issues with footwear. And quite often, more common in ladies and sometimes a family history. So I get patients saying, you know, my mother's feet or my grandmother's feet are like this and I don't want to become
I can tell you,
like
shoes
that.
and heels.
Shoes and heels.
I have it as well.
So the misconception is that people think there is a little outgrowth on the side, and you know we should just go and chop it off, and that will be that done. But the problem isn't just an outgrowth, and essentially is this bone, which is the first metatarsal or the bone of the big toe, drifts outwards, and so the angle between these two bones opens up, and we call that the intermetatarsal angle. And when that happens, if you try and stuff this foot in a shoe, you find that because the shoe might be narrow, it will push the other toe in, and you get this prominence on the outside, which becomes the bunion. And now you can imagine that, you know, feet are different shapes, and if you've got a very broad intermetatarsal angle here, and you want to wear narrow toe shoes, especially ones that have got high heels, what happens is the foot will slide into that narrow toe and try and wedge it inside. And what will happen is that you get a lot of pressure. This foot is falling. You get a lot of pressure on the edge on both sides, and you can get lots of symptoms in that respect. So when patients come to me with that problem, I generally say to them the solution to that is to wear wider shoes, because the wider the shoe, the more accommodating it is. It will hurt less, but also stop this from getting worse because you know you're not shoving your foot in. But something else can happen as well. So when this first ray is not working very well, as you're walking, you tend to not be able to put the weight through the big toe. You end up putting the weight through the lesser toes. And the weight bearing will happen more over here instead of here because this is out of the way because of the bunion. And what that does is that over time, people can get hard skin or pain underneath the second lesser metatarsals. And I don't know if you've heard of hammer toes or toe deformity. So the toes can dislocate and you can get hammer toe deformities. So now you're going to start developing problems on this side. Occasionally people can break these bones. You can get stress fractures because there's so much pressure going through here. You can get arthritis in the base here. They can present with pain in that area. So this is when a simple bunion can become very complicated.
Indeed.
So you start off with a simple bunion here, and then you end up with lots of problems on the other side of the foot. And those are the times that we may consider surgery to correct this and to try and make this side of the foot normal, so weight bearing can then occur on that side. So shall I go on and talk about the surgery a bit more?
Of course, yes, because I think most women will be interested.
Yeah. So when it comes to surgery, it's not just a matter of chopping the end off and narrowing the foot. We have to realign this toe in this bone and bring it back into alignment. And we do that either by breaking this bone or cutting it and pushing the head inwards and fixing it. Or sometimes we can do it at this joint. We can push the foot straight and fuse that joint completely so it doesn't move again. And that way the bunion's corrected, and not just the bunion's corrected, but then the weight bearing returns to this side of the foot, and all the symptoms that they may have on the other side gradually improves, and they can sort.
How do you fix it? Do you put screws?
Yeah, so we can either fix with screws. That's the most common thing that people do. It's a procedure known as scarf osteotomy. You may come across. This is the most common thing that most people use. But there are over 100 different procedures that have been described for this. Some people put a plate on, so you can do an opening wedge plate, and if you're fusing the base, again you can use plates or screws. So there'll be a combination of things.
And what about the mobility and the flexion of the metacarpophalangeal joint? Is it restored somehow?
Yeah. So
or
generally,
is it limited?
So generally, if you have a bunion, the toe is quite dislocated, and although it moves, it doesn't move in the right plane. When we realign it, if there hasn't been a huge amount of arthritis or wear and tear in that, so generally the movement here is acceptable. Okay. And of course, you need movement to wear shoes and heels, and that's generally acceptable.
All right, that's very interesting. Indeed, very common and very painful, especially for women. Right. Yes, and what else do you see very often?
So again, in the foot, occasionally we see neuromas.
Neuromas?
Morton's neuromas.
Morton's, yes.
Yeah. So again, that's a condition that's very common. You can sometimes see it with people with bunions for the same reason, because they're getting more weight bearing on this side, and the nerves can become inflamed. But essentially, what a neuroma is an inflamed or swollen nerve between these metatarsal heads. So the way I might move to this foot, if you don't mind. So
it has a nice colour as well.
It has got a nice colour. It's blue, so it may blend with the background. But so the metatarsals are joined with these thick ligaments, and the nerves to the foot run underneath of the sole of the foot, and they go underneath this ligament and split to go to the toes. Now, there are two nerves that come into the foot, and they split to go to all the toes, but they both send a branch to this middle third space. So that third space nerve is quite thick. If there is lots of pressure and inflammation for various reasons, we talked about the bunion, but for other reasons, that nerve can become swollen or have scarring around it, and it gets trapped between the floor and this other ligament, and it can become very painful. Patients often say that they've got a burning sensation. They sort of point to this side of the foot. They sometimes feel like they've got a marble underneath their feet. They can feel numbness in their toes. And what's interesting is they normally say, when I take my shoes off, it feels better.
Indeed.
And that's because shoes are squeezing these metatarsals together and narrow that space even further. and that can become quite painful. So if a patient says, I've got pain in that area, but it's better when I take my shoes off, then you might alert you to the
You know, we
neuroma.
have these symptoms very frequently, and most of the times we deal with plantar fasciitis. Maybe I believe you will tell us something about it later. Yes. But obviously the diagnosis is made with imaging.
Yeah.
It's difficult to distinguish clinically if it's a neuroma or plantar fasciitis or any other inflammatory process.
Yeah.
Is there anything clinically which gives us a hint?
Well, I mean, specifically between plantar fasciitis, plantar fasciitis, the pain tends to be lower down. Occasionally, you can get it in the middle of the foot. But one of the good tests that we do for neuromas is it's called the Mulder's click or a Mulder's squeeze test. I don't know if you've come across that.
No.
But essentially, we squeeze the side of the foot together, and the patient should get pain in the middle. Sometimes you can push the neuroma into the space and then squeeze, and when you do that, you might feel a click. Because the neuroma jumps out of the space, and that's generally a good sign that they have a neuroma. But if in doubt, ultrasound is very helpful, and we can do this in clinic, and you can quite easily see that there is a neuroma there. The good thing about ultrasound is if you see a neuroma, then you can maybe perform an injection, and we can inject
at the same time.
At the same time, and we can inject
steroid,
yes, and that can give quite good pain relief.
Okay. Is it a repeated treatment, or is it every 3-4 months? Is it something you can repeat depending on the symptoms?
Yeah, I mean, I normally say you can repeat a steroid injection if it's effective. So, if somebody gets a 6 months or a year pain relief from an injection, it definitely is worth repeating it. But, if the injection only lasts for a few days or weeks, then, you can't go around injecting every 2 or 3 weeks. I think that would be too much.
Indeed. Okay, that's very interesting. And what is next?
So I think what you mentioned, plantar fasciitis, that will be the next common things. Yeah,
I have so many.
I mean, there are millions of consultations per year throughout Northern Europe.
Because we are the first contact in GP surgery.
Yeah,
a lot of people.
So plantar fasciitis is essentially plantar fascia. This is this thick band that you see in the sole of the foot. So if you pull your toes backwards, you might do it at home just to test. You see a thick band appearing in the sole of your foot, and this is this blue structure that you see here, and it starts in the heel, mainly on the inner aspect of the heel, and then goes on to join onto the toes. Now, if the calf is very tight and the foot can't come up, as you're weight bearing, you put a lot of stress through that, and you can get little micro tears at the origin, and that's essentially where it all starts. And one of the symptoms that the patients may tell you is that the first step in the morning becomes very painful. And so when I wake up, it takes me a few steps going down the stairs to get drink. It's very painful, and then it gradually loosens up. And that essentially is a sign that the problem is tightness in the calf, because you tend to sleep with your foot pointing downwards. And what that does is that your calf becomes very tight, and then when you wake up in the morning, few steps, it's quite difficult to walk. So the first thing I advise patients is to stretch out their calves and work on that. And quite a few people, just by performing simple exercises at home to stretch out the calf, can benefit quite a lot from that. And these are exercises that are not very difficult to do. You can do it just at home.
So it's beneficial to refer to physiotherapy so they can show them a group of exercises which they can repeat at home, and that will relieve their symptoms?
Yes.
Other therapeutic options, steroids in this case would help?
Steroids can help, but there is a risk of rupturing the fascia. And there are more and more cases being reported of the fascia being ruptured. So I tend to advise against it for two reasons. One, because of the rupture, but also because you're not going to get a cure from it. It may be a pain relief for a few weeks or months, but the problem is in the calf or the other source, and that's not going to go away. So the only time I use steroid injections is if the patient is in so much pain that they literally can't get out of the house. I think then it's useful because you can calm things down, and then we can concentrate on the rest of the treatment. One thing that we use more and more often now is called shockwave treatment. I don't know if you've heard of shockwave.
Do we do them in NHS?
We do them in the NHS, but it's not as widespread in the NHS.
I have never seen a letter from a colleague of yours, specialist, mentioning that.
Is that right? Yeah. So, I mean, we do them in our hospital in the NHS, but we're one of the few that does it.
You're not an ordinary hospital.
No, that's right. That's right. But we do have it's widespread treatment privately.
Okay. Shockwave treatments.
And essentially, it's sound waves. So it's much the same as you must have heard of lithotripsy.
Yes.
It's very similar to that, and it uses sound waves at a much lower force to instead of breaking up kidney stones, causing little micro trauma to the area. And the theory is that after causing the microtrauma, then it kickstarts a healing process. And this is a treatment that we give. It takes about 20 minutes or so. There's a probe that you put over the area, and you deliver shock waves at certain strength. It's a little bit uncomfortable, but most people tolerate it, and it generally takes about 20 minutes to half an hour. And we repeat it on 3 sessions.
3 sessions.
3 sessions, about 1 or 2 weeks apart. And I get quite good results with that.
It's good to know.
Relieving the symptoms.
Oh, that's very interesting.
And then finally, if everything fails, there are surgical options for plantar fasciitis. Most people try to avoid surgery.
Of course.
But certainly there are a group of patients who could benefit from that. And I would quite often surgeons operate on the plantar fascia itself, but that's got quite a high morbidity because you can lose the tension in the fascia, and you can get collapse of the arch. So I try and avoid surgery there. And what I do is release the tight calf muscle, and that can give quite a good pain relief.
Interesting.
But it's quite difficult to try and explain to a patient who comes in with heel pain that they need surgery up in the back of the knee. But certainly there's a group of patients who can benefit from that.
Is it a difficult operation or quite challenging?
No, it's actually quite a simple operation, and the recovery isn't too bad. The difficulty is the decision to operate. Because I think it's quite a difficult group of patients that you need to manage.
That's very interesting. That's the beauty of this science, because you always learn something new, and it's very impressive. Apart from the private practice which you do in your clinic, and I have heard from all the group of your colleagues, there are NHS services which provide amazing treatments.
Yeah.
Most of which we are not even aware because they have advanced, and if you don't come across, you won't know.
That's right.
So avoiding surgery even more the last few years, it's extremely promising.
Yes. Because
rehabilitation, I suppose, is faster without surgery.
Yes, yeah.
And then physio sessions, are they usually prolonged sessions? Prolonged treatments? Do they last many weeks? Or do you think, from your experience, because you know better than anyone, these kind of treatments are treatments with very good outcomes, so the patient less likely will have a relapse?
I think, especially with plantar fasciitis, it's very important that the patient continues with the exercises. So even if we get them better with shockwave or even surgery, if the calf becomes tight again, or if the problem, then that can come back. So I think
it can be a relapse.
Physiotherapy and continuing with exercises is absolutely key here.
Indeed. Right, that's really interesting. I was impressed with the shockwave treatment.
Yeah, so moving up into the ankle, so we're working our way back upwards. The other thing that I see quite often is ankle sprains.
Yes.
Again, it's probably one of the more common joints that gets injured, probably second to the knee. And generally what happens is the foot, you catch the foot and it turns inwards. So inversion tends to be the main source of the injury. And if you look at, in this specimen, you can see that there are some ligaments on the outside, and there are 3 ligaments that hold this bone, the fibula, to the foot. There is one at the front, there's one in the middle, and there's one at the back, and there's three of them that hold the ankle in position. Now, the one at the front is the one that normally always tears, and there's also another one next to it. They're called the anterior talofibular ligament and the calcaneofibular ligament, ATFL or CFL, exactly. and they can tear, and they tear quite easily. So people who sprain their ankle, they normally present with an egg, a swelling on the outside. Normally the inside is pain-free, not much bruising, everything is on the outside, and it's generally on the site of these ligaments. The treatment for those is generally icing, resting, elevation, trying to control that swelling, and ironically is to get the ankle moving and walking on quite early. We know if we immobilize them or don't let them walk on it, they can decondition very quickly, and it actually prolongs their recovery. So one of my roles is to reassure the patients, to say, yes, you've swollen and it's tender, but the treatment is to get going and try and rehab early, and that's when physiotherapy, which you mentioned, is quite important to get the patient involved.
But if the pain is limiting their mobility significantly, do you use brace or anything which is supporting the joint, so it makes the mobility easier?
Yes, there are various braces. You can either have ones that are called the stirrup, that literally just goes around the foot. You can get ones that just put compression over the area only. And then if some of these very sore and swollen, occasionally I use a boot, a moon boot or an air cast boot, and they work.
We see them a lot.
Yes.
We see people around us walking a lot.
Yeah. They are probably being used more than they should be, but they're quite useful in certain situations, and it can encourage and gives the patient a bit more confidence to start using their ankle.
Do you have to apply any surgical procedures sometimes if the tear is significant or is restricting mobility?
Yeah, never in the early phase. I think very high percentage of these injuries heal without us intervening. I think probably 70-80% of patients will heal. But there are this group that develop persistent instability. So they may find that their ankle gives way. And that's because the ligaments have healed, but they heal slightly loose and saggy, and it's not enough to allow the ankle to be stable. Now, one of the roles of physiotherapy is to, so if you imagine the ligament is torn here, but you've got muscles either side that can control the foot. And one of the roles of the physiotherapy is to strengthen those muscles, and they will then take over the role of that ligament. So as the ankle is about to give, the muscles will kick in and stabilize the ligament. And physiotherapy can 70-80% of these patients get better with physio. But if that fails, then we do an operation where we reconstruct these ligaments, tightening them up, and occasionally we use tiny little metal anchors to fix them onto the bone.
Do you see that more often in athletes, or it can happen to during any random activity? It
can happen to anything, to anyone really. It can happen during sports, and certain sports like hockey, netball, football, they're more prone to doing it because you're changing direction all the time.
Or you're kicking.
Yes, yeah. It's generally if you are trying to land on a foot on the side, and that's when it gives way. But ladies on high heels, I've seen that happen quite a lot because it's a very unstable environment, and that can tear. Or quite often people just trip on the pavement and sprain their ankle going off
elderly maybe.
That's right. Yeah. Yeah.
That's very interesting. Actually, these are common things which I think we all come across, especially when you're asked to treat them.
Yeah.
Anything else you would like to mention to us?
Moving on up, we can go to the Achilles tendon. Again, that can be a source of quite a lot of problems. I see quite a bit of Achilles tendon injuries, acute rupture, and that's something that we need to have a high index of suspicion, because you can't we can't diagnose it on an X-ray, and essentially is reliant on clinical examination. And it's not uncommon for people to rupture their tendons, who go to A&E maybe, and they get examined by somebody who's not able to make the diagnosis, and they say, well, you have an X-ray and it's normal, and they say, well, you know, you've sprained your ankle, and they miss the injury. And the problem with that is if an Achilles tendon is ruptured, then there's a gap at the back, and we need to bring the foot down to close that gap and get the two ends of the tendon to meet. So generally we put them in a plaster with the foot pointing down. It's called an equinus plaster to hold the two ends of the tendon together. If that's done immediately or early on, then there's a good chance that the tendon will heal and there will be quite a good function. But if it is missed and the person walks on it, the ends of the tendon go away from each other, and even as little as 3 or 4 days after the injury, it will be really difficult to then get that tendon to heal satisfactorily, and that's the time when you know, we may operate and
to stitch it back.
Stitch it back. So the typical story is that people will say they felt somebody kick the back of their leg. The sort of tendon rupturing is so explosive, it feels like somebody has attacked them, and it's not. You know, we hear that all the time, that, you know, somebody playing squash, he thinks, oh, I thought I got hit by the ball, and they look behind them.
And nothing.
And it's essentially the tendon rupturing. So, you know, if you hear that story, and if there's pain and swelling in the tendon, and if one of the tests that we do is we squeeze the calf muscle, and if the calf is attached to the foot, you see some movement in the foot. But if it's ruptured, then there is no movement in the foot, and that's a very good test to try and
clinical
identify.
test, and simple.
And simple, yeah.
At least you teach us some good clinical skills tonight.
Yeah.
So when we examine patients, it's good to guide, does it not miss something?
Yes, yeah. No, I think picking that up early is quite important, because you know, like I said.
What is the most indicated investigation? Do you think ultrasounds or MRIs are more efficient to establish diagnosis?
For Achilles, I mean, a rupture, I mean, one should be able to pick it up just clinically.
Even clinically.
But if in doubt, I find ultrasound very useful. The good thing about ultrasound is it's dynamic. So, you know, you can move the foot around and look at the tendon. And what you want to look at is, are the two ends of the tendon reaching each other when I put the foot down? And you can do that with ultrasound quite easily, because you can move the foot and see what happens to that gap. The problem with the MRI is you just get a single image, and you don't know what the process is. And you know, ultrasound is quick, easy.
True.
You know, most people now have an ultrasound machine in their clinics, so you know, we can make that diagnosis.
Because I'm asking you because sometimes we tend to send people for investigations before we refer to the specialist.
Yes.
To have more arguments for our referrals to support it.
Yeah.
So we think, in my practice, we can refer directly for MRI.
Yeah.
Some other practices don't have this privilege. So you kind of think, should I send for ultrasound? I might not see much there.
Yeah.
Shall I send for MRI or to the physio team and then take it forward from there and then refer to the specialist, which might be a waste of time?
Yeah. So for a chronic Achilles problem, I think probably an MRI is better, because you know, you can get more information from it. But you know, ultrasound, even in a chronic situation, has good uses.
Very good. Nice.
So there are so many joints and bones. Where do we go next?
Yes.
So the other problem that you see is in the ankle. So ankle arthritis can be a big issue.
Definitely.
And in there, you know, patients generally, one of the most common causes of ankle arthritis is trauma. So people who have had ankle fractures can then develop what we call post-traumatic ankle arthritis. And it's quite a difficult thing for the patients to live with, because you know, the ankle can become more and more stiff. They can lose their flexibility. When the ankle flexibility is lost, you'd rely on the rest of the joints to do the movement. So you can get pain in those joints. You can get pressure in the forefoot. So, you know, the whole foot can become affected. And the surgical options, you know, one of the most common things that we used to do is to fuse the ankle. So we essentially get rid of the joint altogether, and if the joint doesn't move, then it doesn't hurt. It's a very good operation for people who have a very stiff and painful ankle, so they don't have any movement in that joint anyway, so they're not going to miss that movement. And it can be quite reliably effective in getting rid of the symptoms. And
then if you remove the bone there is kind of gap.
Yeah, so we close. Covering the bone is cartilage. So we remove that cartilage on both sides, and then put the two bits of bone right up against each other, and put some screws across it. And then the two bones will heal together like one bone.
I see.
And now that used to be performed open surgery, but now we do a keyhole.
Keyhole?
Yeah, so just tiny little incisions and screws, and the rehabilitation recovery is much quicker.
So you can just stick the bones together with keyhole operation?
Yes, yeah, and that's very successful. But nowadays
very advanced. Very advanced.
But nowadays we're now doing ankle replacements. So ankle replacements, although not as commonly performed as hip and knee replacements, are certainly gaining grounds, and we're doing more and more of them. And of course, the advantage of an ankle replacement is that you don't lose that motion. You can continue with the range of motion in the ankle.
What quality of material you use for the ankle replacement?
So normally it's a polyethylene, so a plastic liner, and so there is a metal fixing that goes into the tibia up here, and there's a metal fixing that goes into the talus, the two sides, and then in the middle there is a sort of movable part that's made out of plastic. And these are called 3-part ankle replacements. Some ankle replacements are 2-part, where the plastic bit is actually attached to one of the components, and it's just that plastic that moves.
So you don't lose the mobility, the flexibility.
So you don't use the mobility. I mean, of course, you know, there will be some stiffness, and the movement won't be as good as a native ankle, but it will, you know, there will be considerable amount of movement compared to the normal
impressive.
situation.
I'm more and more impressed with after every episode I have with London Orthopaedics, London Sports Orthopaedics, because you learn so much, and transplants and new techniques and all these operations happen in keyhole. Impressive, because the rehabilitation time is shorter and shorter.
That's right.
Very impressive. All right.
Okay.
So, is there anything else you would like to tell us?
Well, we can move up to the knee, but no, I think I'll stop at the ankle. Yeah. Is there anything else that you want me to?
No, I think you told us more than I was expecting. I didn't have too many questions because you covered me. We spoke about the knee with your colleague last week.
Good.
So he told us a lot, and I think it was very strict to the point, nice, clear, educative, I would say, even for doctors. You have the privilege of being a lecturer, you teach, so it's very important to know how to transmit knowledge and make people understand. It's a privilege.
Thanks very much.
It was very good, and I'm very, very grateful
well, thanks very much for
coming tonight.
Thank you.
Another educative episode for all of us. And obviously, some people might seek for your help in the clinic. And ask for your advice or to apply one of these techniques to relieve their symptoms. Thank you very much.
Thank you very much.
I'll say good night to our viewers. Ευχαριστούμε πάρα πολύ που μας παρακολουθήσατε. Εύχομαι να βρήκατε κι εσείς τόσο χρήσιμα και ενδιαφέροντα όσα μάθαμε κι εμείς απόψε. Καλό βράδυ, ραντεβού την επόμενη Κυριακή.